Hello, everybody. Welcome here. Today, we are going to talk about the National Health Policy 2002. We know health policies are very important for any country, especially a democratic or welfare oriented country. India is a welfare country. Policy documents actually tell us about the national priorities. What are the national priorities and what are the direction of change? These are very important for understanding the future path of development, future trajectories. And at the same time, these policy documents also help us to understand where we have reached in past years, or you can say decades. So I have prepared a PowerPoint presentation and would like to go for that. For that, I need to share a screen. And yes, yes, our National Health Policy 2002. And this is a part two on the topic health policies. Prior to this, we have already discussed few things in lecture 17. We covered background of health policies in India. We talked about the Alma-Ata Declaration of 1978. Just to recapitulate, 1978 Alma-Ata Declaration, it was stated that health for all by 2000. The target of achieving health for all was for the first time uh, envisioned in this 1978 Alma-Ata Declaration. Then we talked about the first health policy of 1983, which came in the backdrop of this Alma-Ata Declaration. And then we also talked about the important developments in the decades of 80s and 90s, which have played important role in giving shape to the next policy document, that is the National Health Policy 2002. Then in lecture 18, we talked about the Millennium Development Goals. We talked about the health related goals, especially in the field of infant mortality, then maternal mortality ratio, and then HIV/AIDS, malaria, tuberculosis control programs. And before these lectures, we have also discussed the vertical disease control program. So I think you all are familiar with all those previous discussions, because we need to keep in mind the developments which took place in India, especially after independence, because a culmination of all those things will get reflected in the policy document, because policy document actually look at the things in a very comprehensive way, and there is a reflection of the constitution, there's a reflection of the fundamental right and directive principles in the policy documents, and at the same time there is a reflection of the spirit of the constitution, because we are going to take a decision about our future. So with this background, we are moving to our slides. Now, when we talk about the National Health Policy 2002, what is the point of departure? For understanding the point of departure, basically we need to have a look on the past achievements. Now, achievements could be counted on several accounts, but the policy document itself has talked about four important indicators. Now, what are those indicators? The demographic changes, indicators related to demographic changes, basically, which are very important from the perspective of health. So, life expectancy, crude birth rate, crude death rate, and IMR, that is infant mortality ratio. Infant mortality rate. When we talk about MMR, then we make use of the term ratio. When we talk about IMR, we talk about the rate. So it is IMR, that is infant mortality rate. Now, just have a look where we were in 1951, just after independence. If we compare the life expectancy in years of 1951 and 2000, we can see that we have achieved a big milestone, because life expectancy was only 36.7 years in 1951. And in 1981, it was 54, and in 2000, it was 64.6. That means when we say that we have not achieved many things after independence, then we should remember that here are the indicators which show the kind of improvement in quality of life. And it is not getting reflected only in terms of life expectancy, but also in terms of other indicators like crude birth rate. We were 40.8 in 1951 and 26.1 in 2000. Just like that, crude death rate 25 in 1951 and 8.7 in 2000. We know that this crude birth rate and crude death rate are very important when we look at the population growth kind of thing. And then infant mortality rate, IMR, it was 146 in 1951 and it got reduced to 70 in 2000. We talked about some of these indicators in our previous lecture also when we were talking about the Millennium Development Goals. So all these figures are taken from the National Health Policy, and the source of these figures are basically SRS, that is Sample Register System, and RGI, that is Registrar General of India. So now we come to the next step. Now, this is the most important part, the financial situation. Because when we talk in terms of democratic policy or national government or a federal structure, then the funding aspect is very important. The financial situation is very important. This policy document gives an assessment of the financial conditions or financial situation prevailing at that point of time. The public health investment, that is the government's investment in the country over the years, has been comparatively low, and as percentage of GDP has declined from 1.3% in 1990 to 0.9% in 1999. Now, what is this? Basically, what is it that we are talking about? We're talking about the overall investment made by the government from the GDP on a yearly basis, basically. So whatever the GDP is, from that, the government make a contribution towards the health related issues or the public health investment. And from that GDP, the proportion has declined from 1.3% in 1990 to 0.9% in 1999. This is a very small contribution, because when we compare the contribution or the proportion of GDP which is invested in the field of health in developed country, we get to know that this is around 6 to 7% or even 8%. So if we compare the health conditions of developed country and health conditions prevailing in India, we get to know that the proportion of GDP which is invested in the field of health is actually very low, and this is categorically mentioned here. And this was further declined. This has further declined in the decade of 1990s, and it was 1.3% in 1990 and 0.9% 1999. Now this point will come time and again. We need to remember some of those figures. Now the aggregate expenditure in the health sector is 5.2% of the GDP. What does it mean? That overall, I mean, 1.3% is only something which was spent by the government. But what is the total expenditure on health? So if we take into consideration the money spent by people as well as the government, then this total amount is 5.2% of the GDP. Out of this, about 17% of the aggregate expenditure is public health spending, the balance being out-of-pocket expenditure. So out of this total 5.2% of the GDP, actually the government has spent only 17%. 17, that is 17%. So what about the rest? The rest is actually identified as out-of-pocket expenditure. That means the amount is spent by people. We and you people, and from our pocket. So this is out of pocket expenditure. Again, I would like to say that in most of the developed countries, the share of the state is up to the extent of 70 to 80%. In some of the states, we have 100% state expenditure. But unfortunately, in India, it's much lower, and we can see from here that the 2002 policy document categorically suggests that only 17% is the state expenditure and 83% is basically out-of-pocket expenditure. This basically creates huge burden on the pockets of the people at large. The central budgetary allocation for health over this period as a percentage of the total central budget has been stagnant at 1.3%, while that in the states has declined from 7% to 5.5%. So as it was stated earlier also, it was stagnant around 1.3%, that has declined recently, toward the end of the 90s. And because of this central allocation, the budget of the states has also varied because there is a specific arrangement between the state and the union government. And see what is the overall impact. The current, that is 2002, annual per capita public health expenditure in the country is no more than rupees 200. The per capita expenditure, that is the overall expenditure at the level of single individual per capita per person. This is a mere rupees 200. This amount is very small, and that is why the health indicators or health achievements 2 decades back were also much lower because the overall investment was much lower. We will see that there is disparity among the state in terms of these things because some states have very good health indicators. We'll get to know about this in our next point. Under the constitutional structure, public health is the responsibility of the states. In this framework, it has been expectation that the principal contribution for the funding of public health services will be from the resources of the states, with some supplementary input from central resources. That means, as per the constitution, the responsibility of taking care of health needs of people is lying with the state government. It's coming under the state responsibility. In this backdrop, the contribution of central resources to the overall public health funding has been limited to about 15%. The contribution of the states vary. So what is happening that the central government will make 15% and the state government has to make the rest of the investment, that is 85%. So when we talk about the state expenditure, even for that, there is a mechanism that the union government and the state government will make those contributions together. And the central government will provide 15% and the state governments will provide 85%. Now, one more condition when mentioned here is this, that the center will make the contribution only when the state has basically collected the resources. So what happens that the different states in India are having different spending capacity. We have states like Kerala, which is spending a lot on healthcare because it is economically in a better position. It's a much developed state. Again, we have some other states also like Tamil Nadu, Maharashtra, which are financially in a position to make better contribution. Whereas we have states like Bihar or other states at that point of time, Madhya Pradesh, even Uttar Pradesh, which were unable to make that much contribution. And so we can see that the reflection were there in the health indicators. We all know that the states, Bihar, Madhya Pradesh, and even Uttar Pradesh and Assam, these are having very poor health indicators. So because we can understand the cause of this disparity through the funds allocated. And all these things are mentioned in the National Health Policy 2002. Now we come to the important areas as identified by the Health Policy 2002. What are the most important features here? The National Health Policy 2002 is the second such policy adopted by the government after a gap of 19 years. Yes, we know because the first policy was adopted in 1983. The policy also reflects the prioritization of the human development approach. Now, as we stated even earlier, in 90s, the human development approach became very popular, and this 2002 policy is a reflection of human development approach. In human development, basically, the focus is on three specific areas. One is health, second is education, and third is income. So we talked about these things when we talked about the Millennium Development Goal also. Fine. Here we need to remember that this 2002 policy is somehow reflecting the paradigm of human development also. However, it also reflects the large-scale macro and structural changes which took place in Indian economy and polity because of our exposure to the trio of liberalization, privatization, and globalization. But on the one side, we're talking about human development approach, but at the same time, in 90s, we have witnessed large-scale macro level changes, or we can say simply that we have moved towards the goal of privatization. So basically, this move towards privatization got reflected in different arena of social life or state policies, and health policy is again one important direction. The NHP 2002 gives prime importance to ensure a more equitable access to health services across the social and geographical expansion of the country. So, as we talked about the overall health achievements just prior to 2002, we can see that the disparities have become very visible. Basically, because of the differential allocation of the various states and several other contextual factors, the disparities have become very important, and this policy has tried to address those disparities. So if we talk about, if we think of what are the driving principles or values, then one such important principle or value is to minimize the disparity, and that is why this emphasis on equitable access is very much there. Basically, this policy has talked about developing kind of infrastructure which can take care of the health needs of the population at a larger level, including rural and urban, because we know that in India the rural people often suffer a lot because of lack of accessibility and availability kind of things. So this policy document has prioritized equity, spatial equality, and we will get to know that several specific focus or or important programs have been started under this policy to achieve the specific health goal in rural areas, and NRHM would be one such thing. Then a phased time-bound program for setting up a well-dispersed network of comprehensive primary health care services linked with the extension and health education designed in the context of the ground reality that elementary health problem can be resolved by the people themselves. The important thing here is this, that the focus is on primary health care service. Basically, we have been talking about primary health care services right from the Alma Ata Declaration, or much before that, the Bore Committee report submitted in India even before achieving independence. So now this 2002 policy again is focusing on primary health care services. Then an integrated network of evenly spread specialty and super specialty services, encouragement of such facilities through private investment for patients who can pay, so that the draw on the government's facility is limited to those entitled for free use. The point here being made is this, that on the one side we are talking about more equity, and we are talking about emphasis on primary health care. So if the government is going to focus on rural areas and on primary health care, then because of limited resources, it cannot focus on all other possible areas. And that is why this policy suggests that the secondary and tertiary level cares could engage or will engage the other possible partners, that is the private sector. So this is important policy priority of this 2002 health policy. Now, after talking about the special focus on main priorities, let us talk about the specific areas identified in this policy document one by one. We'll try to summarize those points because the details are already provided in the presentation. First, it recommended to increase health sector expenditure to 6% of GDP. As we stated earlier, most of the developed countries are spending 6 to 8% of the GDP on health related issues. And in India, actually, this is much lower, 1.3%. And at the later part of the decade, it got reduced to 0.9%. So from 0.9%, the target was to reach to the goal of 6%. And with 2% of GDP being contributed as public health investment by the year 2010. So in 2002, the target was to achieve the goal of 6% of GDP, and by 2010, it was specifically defined as 2% of the GDP. But we know that even today, we are not in a position, we have not achieved this target of 2% of GDP. We are actually lagging behind. And then with the stepping up of the public health investment, the central government's contribution would rise to 25% from the existing 15% by 2010. Then it also talked about increasing the contribution of the central government from 15% to 25%. And then third important thing is an increased allocation of 55% of the total public health investment for the primary health sector. As we stated, the focus is on primary health sector. So how can this focus be maintained? By increasing the allocation. So it was stated that the 50% of the allocation will be in the field of primary health sector, and the secondary and tertiary health sector being targeted for 35% and 10% respectively. So out of the total allocation, basically a land share 55% will go to the primary health sector, 35% and 10% to the secondary and tertiary healthcare. And that is why, because there is a lack of investment from the government side on the secondary and tertiary care, that's why there is a scope of investment from private sector in the tertiary care. Second, the gradual convergence of all health program under a single field administration. We have been saying that in India, basically we had followed a vertical disease care program, and the vertical disease care program were basically disease specific. So there were several parallel programs. Now this policy talks about convergence of all health programs. However, some of the specific vertical programs, like those meant for controlling tuberculosis, malaria, HIV/AIDS, will continue, but the ultimate goal is getting reflected in terms of some kind of convergence in health administration. The presence of state government officials, social activists, private health professionals, and MLA MPs on the management board on the autonomous bodies. So when we talk about health administration, then there are several other specific details are provided, and a convergent approach is basically suggested. So it will not have only people from medical profession, rather people from all other possible dimensions, especially the political representatives, and then government official and social activists. The inclusion of the social activists and private health professionals is very important here. Then all rural health staff should be available for the entire gamut of public health activity. Basically, it's again talking about convergence from vertical disease control program to basically a comprehensive healthcare program. So these policy shifts have been highlighted here. Rural health staff would need to be trained and reoriented. Yes, all those things have been mentioned. The policy envisages kick-starting the revival of primary health system and recognizing the practical need for levying reasonable user charges for certain secondary and tertiary public healthcare services for those who can afford to pay. So the focus is on primary healthcare. And then another important thing is to introduce user charges. I remember when the government introduced those user charges, even in the government system, then there were huge criticism, but well, the government was very categorical because of the availability of resources kind of thing. So these user charges got introduced. I think you all understand what is this user charges. When you go to some of the government hospitals, then you may have to pay a small amount for certain diagnosis, certain test kind of thing. Some of the things you may get free of cost, but for few things you may have to pay some fee, and that is known as basically user charge. And then the state government would consider the need for expanding the pool of medical practitioners to include a cadre of licensed of medical practice as also practitioner of Indian system of medicine and homeopathy. Now, two important things are mentioned here way back in 2002. It talks about introducing a cadre of licentiates of the medical practices. That means keeping in mind the lack of availability of sufficient number of medical practitioners, the state governments can introduce a cadre of people who may not have the degree of MBBS, which is considered necessary as of today at that point of time. And so they may have parallel medical staff. Now, something which was prevailing even earlier, and it was also mentioned in the Bore Committee report, the term licentiates are mentioned in the earlier committee reports. But here it is suggested that to fulfill the need of having enough number of medical staff, the government is suggesting this, and state governments can go for this. However, this was uh, not very widely accepted. On the other hand, the other suggestion was accepted very well, and that was related to Indian system of medicine and homeopathy. So at that point of time, as of today, we all talk about the Ministry of Ayush, AYUSH. That is basically an acronym of Ayurveda, Yoga, Unani, Siddha, and homeopathy. But earlier it was known as Indian System of Medicine and Homeopathy. So this policy suggests that we can take medical staff from this system, Indian or indigenous system of medicine also. We talked about this when we talked about medical pluralism. Then further it talks about making available the paramedical manpower of allopathic disciplines so that the deficit related to health staff could be properly addressed. Then it also talks about the rules for contract employment. That means at that point of time, it was well realized that there is shortage of medical staff and this needs to be addressed. So all possible mechanisms were actually devised to address the shortage of medical staff at different levels. Then enforce a mandatory 2-year rural posting before the awarding of the graduate degree. Now, this was again a very important guideline that when people are acquiring or getting the degree of MBBS, then there should be a mandatory 2 years posting in rural areas to address the needs at the rural areas or where there is not much availability of medical staff. So those radical suggestions were also coming. Then a need-based skill-oriented syllabus with a more significant component of practical training would make fresh doctors useful immediately after graduation. That means the curriculum should be addressed in such a way that there should be there should be some kind of skill, or you can say knowledge or training, which could be utilized for the immediate benefit of people. Then the policy also recommended a periodic skill updating of working health professionals through a system of continuing medical education so that people can get to know about the new things, new development in the field. And then creation of additional seats for postgraduate courses, because we know that the specializations are actually developed at the level of post-graduation during the medical education. So it recommended additional seats, and we know that the seats have been increasing gradually. Then an important development is basically involvement of the panchayat bodies. We know that in 1990s, panchayati raj institutions became constitutional or constitutional body, statutory bodies. And then this policy categorically talks about involvement of the panchayat raj institutions in the health policies, especially in the rural areas. And we know that the National Rural Health Mission, which came into existence in 2005, it talked about several new health functionaries, and we talked about ASHA, and basically the selection of ASHA was taking place at the level of the panchayat involving the PRI representatives. So it suggested policies, and then those things got implemented at the level of the programs also. Then it also talked about the ratio of nurses versus doctors and beds. That means talked about increasing the presence of all those things. Then a very important guideline of this policy is related to the pharmaceuticals. Basically, we have been talking about several reports of several committees, but the issues related to pharmaceutical companies or the medicines were not much addressed. This policy categorically talks about, we'll talk about these two, three important guidelines here. The policy emphasizes the need for basic treatment regimen in both the public and private domain on a limited number of essential drugs of a generic nature. Now, when somebody is going to medical practitioner, then the practitioner is suggesting certain medicines. Now, what kind of medicine is this? Because very often we go to the market and we get to know that the similar composition is available at different prices. Basically, the same composition is prepared by different medical uh, different companies, and very often the prices vary. So what is suggested here is this, that the essential drugs of a generic nature which are of general nature, whether the salt is the common, and the doctor should focus, the medical practitioner should focus on those generic drugs so that the cost could be minimized. To encourage the use of only essential drugs in the private sector, the imposition of fiscal disincentive would be resorted to. And further, we often also know through our practical day-to-day experiences that very often doctors suggest many medicines which may not be considered very important or necessary by other practitioners. So the essential drugs should only be prescribed at the private sector, right? There are criticism that very often some doctors suggest unnecessary or not essential drugs. So this point has been addressed through this policy document. And then the production and sale of irrational combination of drugs would be prohibited. Now, it is again irrational combination because very often the essential salts or compositions are somehow combined with certain non-essential combination, and the medical practitioners prescribe those medicines which have very high cost. So that kind of irrational combination or not essential combination should not be practiced. All those guidelines are there in this policy. Then setting up of an organized urban primary healthcare structure is also talked about. So as we talked about the rural healthcare infrastructure, and along with that, the urban healthcare infrastructure is also talked about. In the rural areas, basically, we have the three-tier system, that is the primary healthcare center, then the sub-center, and then the community health center. In urban areas, it is suggested that we can have the two-tier system. Then this policy talks about establishment of fully equipped trauma care network in large urban agglomerations. So when we have medical emergencies, we need the trauma care networks. So there should be a network of trauma care centers in all urban agglomeration, large cities, so that those who are in immediate need of medical facilities may get those medical facilities, and the precious lives could be saved. Then upgrading the physical infrastructure of mental hospital institutions at the central government expenses so as to secure human rights of the vulnerable segment of the society. Basically, in India, we can see that not much uh, focus has been on taking care of the mental patients. So this policy document is talking about mental hospital and institutions. I've talked about this point at length at the end of this presentation also. We'll come to this, but yes, this is important that the policy has talked about the mental hospital and people suffering from mental problem. Then, in view of the over dependence on mass media, the policy proposes to focus on the interpersonal communication of information and on folk and other traditional media to bring about behavioral changes. Now, basically talking about infrastructure or system of medicine is not enough, because through several research papers we get to know that often people's behavior related to health or their healthcare behavior is not changing. So this policy document suggests that several behavior changes are required, and for those behavioral changes, basically mass media can be used, and the folk system, folk songs, folk art, which actually symbolize rural people or ethnic groups, or very often the tribal people. So those channels can also be used to create health awareness and health consciousness. We need to remember that HIV/AIDS became a very important disease in the 90s, and NACO got established. So it was very important to create health awareness, and for that, basically those mass media things were supposed to be utilized, and for that the folk uh, systems could also be the folk songs and folk music, etc., folk dance, etc., could have also been used. And then giving priority to a school health program, again the health awareness component is here, and how to increase health awareness. For that, the school health related programs also need to be introduced, it was suggested, and basically preventive health programs were introduced. Then an increase in government funded health research center. So it talks about funding the health research system, and then it talks about private insurance instruments, basically how to address the burden of health care. For that, a provision of introducing health insurance instruments was made in this policy document. That means if somebody is willing to go for purchasing a health insurance, there should be ample choices for that. And then social health insurance scheme, basically when individuals can go for individual level health insurance scheme, but when we are living in a community life and there are people who cannot take care of their health insurance needs, then the state can address this issue by going for some kind of social health insurance scheme, that is a collective health insurance. And then involvement of the non-government practitioners, basically we know that with liberalization and privatization, there was growth of or a rise of the third sector, that is the non-government sector. So issues which cannot be addressed by the government or the private sector as such can be addressed by the non-government sector, and so the non-governmental practitioners have been brought into the focus, NGOs have been brought into the focus, and a fund is earmarked to promote the involvement of the NGOs and the third sector. And then it further talks about making use of the information technology for developing network, and then baseline estimate, because the data is very important. We talked about infant mortality, maternal mortality ratio, and all those things. For that, the data is very important. So how to develop this data related to disease or healthcare facilities, for some kind a baseline estimate is required, and it was talked about there. And then the need to establish national health account conforming to the source to users matrix structure would help in estimation of health cost on continuing basis. Basically, the cost of healthcare, for that some kind of national health account should have been developed. And then it also talked about the women health related programs, and we know that in the aftermath of this policy, several maternal healthcare and child healthcare programs were introduced. And then it also talks about the code of ethics to be notified by Medical Council of India, so that the non-ethical practices could be controlled. So Several other things have also been addressed. Standardization of the food items, because food adulteration is a huge health concern. So how to standardize those food items, it has been mentioned here. Then the screening of the health condition of the workers, basically occupational health is something which is very important. We have talked about occupational health. It is categorically mentioned here that the screening of the health condition of the worker should be there. Then health services on a payment basis to service seekers from overseas. Now, overseas people who are coming here from outside the country, there should be some kind of provision for providing healthcare services to them also. And this was labeled as medical tourism. That means when people are coming from outside, some kind of a tourism is this is, and it will serve their medical needs, and at the same time it will serve the financial problem of some of the corporate hospitals. So a combination was proposed like this. And then a national patient regime for the future, which while being consistent with TRIPS. What is this TRIPS? This is trade related international practices, right? And so a national patent regime. I'm sorry, this is actually related to patent. What is this patent? Basically, when there is a new scientific invention or discovery, then this is basically a copyright issue, and this is getting patented at the international level, right? So in 90s, basically, when we witnessed the globalization and privatization and this structural reforms, then those trade related laws became very obvious. World Trade Organization came into existence, and all those things happened. So they talked about the patents. So how to protect the patent? For that, some kind of universal standards needed to be followed, and those provisions were actually included, so that if a particular country or a corporation or company has invested in a particular composition, or for that matter invention or discovery, then those patent rights should be reserved and honored. And then, as we stated earlier, there is much focus on mental health disorder. Serious conditions of mental disorder require hospitalization and treatment under trained supervision. Mental health institutions are woefully deficient in physical infrastructure and trained manpower. So NHP 2002 will address itself to these deficiencies. Categorically mentioned that the infrastructure facility related to treatment of the mental health patient is very deficient in India, and this policy needs to address these things. So those were the important issues related to this National Health Policy 2002. We have addressed some of them, but there are many other things. Although the points have been covered, anybody interested can go to the policy document, which is readily available in the website of the government, or even a Google search can help you to reach to that policy document. So thank you very much for being with me. I'm closing this.